Hey everyone, and welcome to today's Explainer. Today, we're diving into one of the most high-stakes, highly orchestrated moments in human existence, the very first moments immediately following birth. Now, we often think of birth as this seamless, natural miracle, right? But the reality is that the transition from the womb to the outside world requires massive, instant, physiological changes from the baby. And when those changes don't happen perfectly, well, there's a very specific, rapid-fire medical protocol that kicks in to save that tiny life. We're going to unpack exactly how medical professionals navigate the chaos of the delivery room, handle birth injuries, and even build nationwide safety nets for our most vulnerable patients. Let's get into it. Here's the roadmap for our Explainer today. 1. The first crucial breath. 2. Step-by-step resuscitation. 3. Understanding birth injuries. 4. Essential newborn care. And finally, 5. Facility-based safety nets. All right, starting right off with Section 1, the first crucial breath, and the reality of the delivery room. Picture this. You're in the delivery room. The exact moment a baby is born, a clock starts ticking. The entire medical team is zeroed in on one defining action. Is the baby crying or breathing? What's absolutely staggering here is the number 10%. See, the vast majority of newborns, about 90%, are vigorous term babies. They cry, they breathe, they get handed straight to their mom. But that remaining 10%, they require respiratory assistance right out of the gate just to take that first breath. And considering almost a quarter of all neonatal deaths are linked to birth asphyxia, which is a lack of oxygen, the stakes literally could not be higher. That intensity brings us to Section 2, step-by-step resuscitation, famously known as the Golden Minute Protocols. When a baby falls into that critical 10%, medical professionals rely on a superstructured, rapid response system. There's literally no time to second guess. They follow what's known as the ABCD protocol. Block A, the airway phase, happens in an absolute blur. The baby is received in dry, warm linen, and the immediate question is, are they breathing? If no, the cord is cut. The baby goes straight under a radiant warmer so they don't lose heat. They're dried, their head is positioned perfectly to open the airway, they're suctioned if there's any meconium blocking things, and they're physically stimulated to breathe. This entire sequence, it takes no more than 30 seconds. After those frantic first 30 seconds, the team is evaluating the baby's respiration and heart rate all at once, which brings up a really crucial question. What happens if that heart rate is below 100 beats per minute or the baby is just gasping? Well, you definitely don't wait around. You escalate. That triggers an immediate jump to blocks B and C. In block B, the team forcefully assists breathing using positive pressure ventilation, or PPV, with a bag and mask, aiming for about 40 to 60 breaths a minute. Now, if 30 seconds go by and that heart rate drops below 60 beats per minute, they instantly jump to block C, circulation. This is where chest compressions start. They use a 3-to-1 ratio, 3 compressions for every 1 breath, and they are aiming for roughly 120 events per minute to maximize oxygen. It is an incredibly intense, perfectly coordinated dance. Now, if the heart rate stubbornly stays below 60 beats per minute after almost a minute of chest compressions, we hit block D, drugs. The team administers epinephrine, usually through an IV or a breathing tube. Throughout this whole ordeal, they are constantly evaluating. But we have to acknowledge the somber reality of these protocols too. If the baby's APGAR score is 0 and there's absolutely no detectable heartbeat after 10 full minutes of resuscitation, medical guidelines say it might be time to discontinue efforts. It is undoubtedly the hardest decision in the room, but it's guided by the reality of infant mortality predictors. Okay, let's take a breath. Once the immediate, heart-pounding tension of that golden minute passes, babies are routed to different levels of care based on how they did. The 90%? They get routine care right on mom's abdomen. If a baby just needed a quick burst of ventilation under a minute, they get observational care. They stay with mom but are checked every 30 minutes. But if they needed PPV for more than a minute, they're at a much higher risk of deteriorating. They get immediate post-resuscitation care, meaning a direct transfer to the neonatal intensive care unit for specialized monitoring. It's a very clear, organized system. Let's move on to Section 3, understanding birth injuries and the physical toll of delivery. Shifting gears away from respiratory distress, we really need to look at the physical trauma that can happen. Birth is a seriously tight squeeze. The tremendous pressure passing through the birth canal can cause some very recognizable injuries, especially with larger babies or a super long labor. A classic distinction doctors look for involves head injuries, specifically caput succedaneum versus cephalhematoma. Caput is essentially severe swelling of the soft scalp tissues that actually crosses the suture lines of the skull. It looks bad, but it usually disappears harmlessly in a few days. Cephalhematoma, on the other hand, is actual bleeding trapped under a fibrous layer, so the swelling does not cross that suture line. It shows up hours later as a lump, takes months to heal, and can even cause jaundice as those trapped red blood cells break down. That physical toll shows up in a few other ways, too. You might see temporary facial paralysis from the pressure of forceps, or Erb's palsy, which is an injury to the nerves supplying the arms during a rough delivery. Now, what sounds absolute terrifying to a new parent is a clavicle fracture, a broken collarbone. But get this, it's actually the most common birth fracture, and it blew my mind to learn how fast newborn bones heal. Within just 10 days, a firm lump of new bone forms, and it heals perfectly. Similarly, a bright red band in the baby's eye, a subconjunctival hemorrhage, looks incredibly alarming, but it's super common, completely harmless, and usually absorbs in about a week.
All right, on to Section 4, Essential Newborn Care, or how we stabilize the next generation.
So we've talked a lot about emergencies and injuries, but what about the foundational care that every single newborn needs? Whether they're born at home or in a state-of-the-art hospital, these 5 pillars are absolutely universal. First up, prevent hypothermia using warmers or skin-to-skin kangaroo mother care. Second, establish breastfeeding within the first 30 minutes. Third, prevent infection through sterile cord care and specific eye drops. Fourth, administer vitamin K. This one is super important because babies are born with very low levels of it, and the shot prevents dangerous bleeding disorders. And fifth, kick off the immunization schedule right away with vaccines like hepatitis B. This is the absolute baseline checklist for a human entering the world. But the care doesn't magically stop when the doctor walks out of the room. Parents are the first line of defense. Before they even get discharged, it is so crucial they understand the red flags. If a baby develops jaundice within the very first 24 hours, fails to pass meconium in 24 hours, has persistent vomiting, or has sudden unexplained temperature shifts, those aren't wait-and-see situations. Those are immediate medical emergencies. Which brings us to our final part, Section 5, Facility-Based Safety Nets and the Macro View of Neonatal Care. Let's completely zoom out for a second. We've been looking at the individual bedside, but how do entire healthcare systems manage this on a macro level? How do you actually build a safety net to catch millions of babies? Well, to understand the sheer scale of the problem, listen to this staggering statistic. India alone accounts for 30% of all neonatal deaths globally. 30%! That is an enormous systemic challenge that requires massive, dedicated healthcare infrastructure to fix. To put that into perspective on the ground, that 30% translates to a neonatal mortality rate in India of 37 deaths for every 1,000 live births. And the timing of these losses is what's really crucial. Over 46% occur in just the first 2 days of life, and a massive 73% happen within the first week. The data is screaming at us here. Those first 7 days are the most critical battleground for a newborn survival. So, how do we combat that? By deploying a highly organized, tiered safety net. Think of it as an escalation timeline. In minute 1, you have the NBCC, the Newborn Care Corner. This is a mandatory space located physically inside every delivery room, equipped with a warmer and resuscitation kit. If the baby needs more help over the next couple of hours, they are moved to the NBSU, the Newborn Stabilization Unit, at local community centers to get stabilized. And for those critical first 7 days, there's the SNCU, the Special Newborn Care Unit. These are much larger facilities at district hospitals equipped to handle very sick newborns who might not quite need a full mechanical ventilator. It's an entire system designed to catch babies before they fall through the cracks. What about rural areas, right? Places where there simply aren't enough specialized pediatricians on standby 24/7. That's where FIMCIN comes in. It's a bit of a mouthful, but it stands for Facility-Based Integrated Management of Neonatal and Childhood Illness. This training package is brilliant because it actively empowers local medical officers and staff nurses. It builds their capacity to manage neonatal illnesses right there on the front lines. It's really all about distributing life-saving knowledge to the people who are actually in the room when that baby needs help. So, where does all this leave us? From the incredibly intense 30-second window of that golden minute, to monitoring a healing collarbone, to these massive national safety nets, the sheer scale of effort humanity puts into protecting a newborn's first days is truly awe-inspiring. But knowing those statistics we just went over, the challenge is far from solved. So I'll leave you with this. How can we further innovate, train, and support our healthcare structures to ensure that absolutely every single baby gets that healthy, vigorous start? It's a huge question and one that continues to drive the entire future of global newborn care. Thanks so much for joining me on this explainer, and keep learning.